Good morning, colleagues. Just while waiting to begin, I want to check whether online you can hear us. Christian, are you?
Yes, yeah, so.
Good. Okay, that's great. That's great. Then, colleagues, it's 10 o'clock. Warm welcome to this public meeting of the Board of Directors of Northumbria. I'm Paul Reynolds. I'm the Trust Chair. Can I remind you, first of all, that this is a public board meeting. We're being filmed. I have to express a quick disappointment. Our ratings have been going down. We have been having several hundred watching our board, and it's dropped a bit. I have a feeling that you guys are not putting on a decent enough performance to bring in the crowds. I'm glad to say, though, we are still rating 15 times as many people watching us as watched the ICP board the other month. No lessons we can draw from that.
Not much of a benchmark.
Not much of a benchmark, I hear. So, if public board is being recorded, that's a reminder, therefore, that we use the microphones. Welcome to those members of the public that are observing, including we've got still got one management trainee, so very warm welcome to you there. And we also have observers from NHS England as part of our process of applying for Advanced Foundation Trust status. Welcome in particular to Christian Laidlaw and Lisa Remedios, and I think we may be being joined by Anne-Marie Hania and Anya Keeping later on in the meeting. Have I got that?
Yeah, Anne-Marie is just having internet issues. Apologies, so she won't be done when she can. It might well be on her phone.
Okay, well that's grand. You'll all be welcome, and as the pattern we've been trying to follow through the subcommittees, at the end I'll invite any comments you've got, but don't feel you have to, but it's we'll give you the opportunity for comment or question at the end of the board. That's clearing the ground. Apologies for absence.
We have apologies from Ruth Compton, Sarah Penny-Redler and Alistair Blair.
Okay, declarations of interest above and beyond the normal. And can I check about any other businesses that you're intending to bounce me with? None. That saves us a bit of time later on. Minutes of the last meeting, 27th of November, they're always good, still good. Are we happy with them? Any issues arising out of them? No. Then the action log. Oh, don't you just love a clear action log with either complete or not yet due? So there's nothing I need to raise from the action log. Anybody else? Yes, Richard.
Yeah, just comments on the first one, 11125. Insurance Committee last week, there were some wider concerns expressed about the CBX and whether it's fit for purpose, and I wonder, as well as looking at the insurance restrictions, whether we just need a wider look at whether CBX is fit for purpose and what options there may be for exit.
Paul, what do you think?
So in particular that building, the contract ends on the 1st of March 28, and unfortunately we're tied into that building until that date. So Fleet used to be in and didn't have a history of issues on the site. They were in for 5 years. We are pursuing it with the landlord, and we're thinking through options. We have been able to accommodate the staff on other sites. We'll definitely vacate that facility at the end of the lease term.
Okay, it's not a cracker, is it? There's been a history of problems with heating and etc.
I mean, it's fair to say there are issues on the site.
Yeah.
The landlord might have a different view.
Absolutely.
Yeah.
Okay, so I think probably, Richard, whilst it's fair enough to flag it up, the options aren't that great, and we probably need to see it out through to March 2020. Are you content with that? Thank you. Anything more? Then we're into Bijou's Chief Exec's update.
Yeah, so you will have seen a copy of the dashboard in your pack. So this is for month 9, December. Generally, a really strong performance, both from a financial point of view in terms of hitting our plan and also operationally as well, around our operational performance metrics. Whilst they're not quite where we want them to be with regards to constitutional standards, we are well above the national position on all of those metrics, and the team continue to drive performance around the 4-hour standard, cancer standards and RTT, with a recognition that for our patients and for our staff, with recognition that waiting is not good. We know our patients don't like waiting, our staff don't like wasting time either, and that continues to be a focus across the board. A couple of other points to note: our patient and staff experience, despite the pressures, have remained strong, both on our real-time and our patient perspective results. Joe, I think, has got a more formal report later on in the pack, so I won't go into that too much at this point. And then a couple of things to highlight in that we have our new contractors now formally being appointed for the Berwick hospital build and the Medicines Manufacturing Centre, so Robertson's for the Berwick build and Opus for Medicines Manufacturing. We managed to hit 74% for the National Staff Survey, which was a phenomenal response rate from our staff. It's the highest that we've ever managed to achieve. That's over 8,000 staff that have responded to the survey and will be informing us of what they think, what we need, what we do well, and what we need to improve on. Those results should come out in March, and we'll obviously do a further deep dive through PCC and bring those results back to board as well. We have remained in NOF 1, so those results came out at the back end of December, so we still remain in segment 1 of the NHS oversight framework, which is a good position for us to be in. And as part of our forward thinking and planning, we are going through a process. We've got colleagues from NHS England today online, going through the Advanced Foundation Trust process, and we continue also to develop our plans for becoming an integrated healthcare organisation / contract holder. And then I think it would be remiss of me not to mention winter pressures. So we have continued to feel the pressure of winter across all of our sites, and in particular across our emergency departments. Whilst we're starting to see flu and RSV beginning to subside, the pressure does remain both on the NSEC side for admissions, but also in line with discharges, and probably a bit of a struggle in terms of getting patients to the right place that they need to be and getting them home in a timely way. We continue to work with partners on how to facilitate that, but that does remain a pressure within the organisation currently.
And to be sure, a lot of those themes are picked up later on, so some of the details we can pick up later in the agenda. But any questions and reflections? We're happy to receive. I know that this dashboard has also gone through scrutiny elsewhere along the way, so thank you very much indeed, Adrian. But stay on, because it's thee and me that have done the report providing an update on engagement. Do you want to kick off and then I'll add?
Yep. So this is the quarterly report that we provide in terms of the engagement activities that myself and Paul have undertaken in line with one of our strategic objectives on the BAF. And you will see in the report there that we continue to maintain our engagement across our system, both at ICB level and also across the provider collab with primary care and local authority in particular. And I think that has come into its own in terms of the relationships that have been formed and the development of the IHO as well. I've just come back this week from a national NHS England Chief Execs meeting, which was really positive in terms of what we need to do over the next 6 to 8 months, particularly with regards to some of the performance recovery that we have seen and where we need to get to next. And we also had a visit from Penny Dash a couple of weeks ago, the chair of NHS England, to Hexham and NSEC site. In particular, she was interested, and we were able to share our model of how our base sites allow for a natural environment for neighbourhood working, how we use a very different workforce at our base sites, and how actually we've been able to deliver care in a much more networked arrangement as a consequence of this. And then also that separation between emergency and elective, and how that's helped us to maintain some of our performance metrics.
Good, and the only bit I really want to highlight is, as usual, we've summarised the issues that come up in governor constituency meetings. Thank you all of those of you that attended the governor's meeting last night, which I thought was extremely positive, and they were very, very supportive. It almost felt like we were about to get a standing ovation for NHFM and their performance. It was getting embarrassing. But looking at the list of issues that come up in the Governor's constituency, one of the common themes is the future of the role of governors. We're working hard on that. I might indeed in a moment invite you, Ross, just to update us on the process where we're going through. I think the sooner we manage to come to a clear view for ourselves, and the sooner, dare I say it, that the Department of Health comes to a clear view of its expectations, the easier it will be to continue the positive engagement we have with governors. They also, as usual, they engage quite well in some of the local issues. So they've been part of the traumas we've been going through in Berwick throughout the process. They've been part of the redevelopment at Hexham and helping us think through the communications and the lessons throughout. But Ross, would you mind just saying something brief about where we've got to on the future of the governors?
Yeah, thanks, Chair. So this came about because in the 10-year plan, it alludes to the removal of statutory powers for governors. There wasn't a great deal of clarity other than that's the intention and direction of travel, so nationally they're working through that. Myself, Laura Liu, Laura Olsen, a group of us have been attending various kind of peer events and working with NHS providers just to try and get a clearer view of what that might mean in the future. We've met with other trusts as well, a similar sized trust, to understand the challenge there. So we're working through all of that. I've had good conversations with the lead governor. I'm due to have a couple more meetings tomorrow and then I'm going to meet with the wider government group just to really explain what we know and what we think the future might hold. And I think the overriding priority for us is not losing that really important community involvement and public voice that we've been so proud of in Northumbria over lots of years. So we're developing a bit of plan between Joe, myself and Chris, and just think about how we triangulate lots of the engagement activity that we have and lots of the complaints, the PALs, and bring all that together to make sure that we've still got that exemplary way of engaging with the public and the community spread out so geographically. So nothing hard and fast yet, but we are working towards that and see where that ends up.
Thank you, Ross, and as those ideas start to form, we will be bringing them back to board for consideration. Any questions on that, or indeed now any questions or challenges to Bijou and I on our report? I hope we provide some assurance for that aspect, that strategic objective of effective engagement with partners within the system. Thank you very much indeed. Then let's move straight on into the patient and staff experience section, and we kick off with the patient and staff stories. And Joe, on the face of it, this looks like an exceptionally positive one. We tend to alternate between ones that kick us in the belly and ones that kind of stroke us a little bit. And this one, you start reading the story from Mary and it feels like it's a stroke, and it is, but on the other hand it's following some quite challenging experiences she had previously in Ward 9, I believe. So over to you, Joe.
Thank you, Chair. Yes, so I think you're absolutely right. You know, we do bring a broad range of experiences through our stories for both patients and staff, and for me, this is a little bit of a mix. So unfortunately, the lady in the past had an experience within the trust that she'd had to make a complaint for, and that had affected how she felt coming into the hospital for care. I think the absolute basis for the two stories today is about human connection. And those small gestures and the difference that it makes to our patients and to our staff. It's really important, those interactions, because they help to build trust, and this is quite clear through what the lady says about how she feels about the care she received and how it reduced her anxiety because she did have that. She really was grateful for the kindness and the compassion that was shown. I think also those small gestures of kindness really personalised the care. She loved the Haribo, she really enjoyed the Haribo, so do I. Those little things make a difference. My mum was a nurse for 40 years and she talks about that continually. The real small things that make the difference to our patients. It also helps, as she says in her story, it helps for our patients to feel safe, to feel respected and to absolutely feel valued. The member of staff talks about in a similar way through the care that she gives, that it really helps to build those connections, those human interactions, because we're in a busy world where we're delivering medical care, and it's important that we maintain those human connections throughout the process. She also talks about how important it is to receive the positive feedback, and we talk about this in lots of ways with our staff, how important it is. That recognition and gratitude, especially if you have had a complaint at a certain point in the week and you get that feedback, so it really makes a difference to our staff, understanding and knowing the care that is making a difference to our patients. And I thought I'd just pull out, Veronica, the fact that, again, the lady mentioned the domestic and the difference, and we talked about that last night, and absolutely we see this time and time again in our patient experience. It's staff of all levels that make a contribution to the experience of our patients.
Thanks, Joe. That's quite a story. Can't help thinking that Haribos are an awful lot cheaper than some of the drugs we issue, and are probably more effective in improving patient outcomes. Anybody got any comments on this powerful patient story? Steve?
I think this one's just all about culture, isn't it? And I think our task here is to consider how we can take responsibility for spreading that culture in terms of promoting it, reinforcing it, sharing it amongst the staff teams. As Joe said there, this story covers a wide variety of our people, and I just think we need to take steps to, for this one, kind of capture it and present this. I just wonder if we've got any plans to do so, Joe.
I think it's something that we do continually see through the work that we do by the experiential programme, the real-time, particularly the inpatient. The comments that patients make, the staff, the coordinators are always great efforts to make sure that they record those reports, then go to the ward team within around an hour to 2 hours of it being collected, so it's about my shift today. And if a member of staff is named about an act of kindness or a respectful interaction, we will always make sure that that's recorded in the report. And we know that our staff really value that.
But it's quite a thing, isn't it? And I wonder if the comms people can reflect on any clever ways we can work on it. I've got Jeremy, and then I've got Veronica, and then Anna.
So, just really to say, because you were commenting on the good and the bad stories, but I think it is really, really important if we want to reinforce some great care that goes on and spread that. It is really important that all parts of the organisation take the time to celebrate that and congratulate those involved in the learning from deaths process. Everyone does tend to focus on trying to pick out all the things that go wrong, but it is really important, and we keep saying this to the reviewers, to pick out all the processes that go right, those little emails to the people who've done things well. These are also important, I think, just to say thanks very much for the story. It's really important that the board takes part in that as well.
Very good. Veronica?
Yeah, I think for me, when I was reading it and picking up on what Steve said about culture, I related it very much back to the values that we're refocusing on, of patients first, respect, and always improving, because I feel if you apply those to this story, they're all evidenced within that, and I think that's a good link to have, to keep linking it back to those very simple 3 key values that we have. And if you sort of layer them on to any patient story that we have, or even staff experience that we have, and if you can see those values evidence, then I think that's always very positive and it's very clear here.
Powerful, yes. Hannah?
So the line that stood out for me in Kate's story was, I make a difference every day at work, but it doesn't get recognised. So there's something for me about local reward and recognition. I just wanted to share with the board. We had a conversation at the Medicine Operational Board earlier this week about how we spread and adopt some really good initiatives. So those that are coming to visit ED will hear how they have a mechanism for local reward and recognition, and we're going to look to spread and adopt across medicine, so some of these small things do get recognised.
Very good, and in a moment, Phil, but Joe, when you come on, I wouldn't mind picking up, because I think we've got some evidence on do staff feel that they're recognised, etc. So hold that until your next section. Phil?
Sorry, it's just a follow-on point from that. But on the net walkabouts, which we've got this week and next week, could we actually include a stopover in Ward 9? Because it would be nice to actually specifically go and talk to them about the feedback.
Very good. Very good. Let's make sure we do it. Chris?
Just quickly to remind board and colleagues that we have the Great Text system, where colleagues can do on big numbers, but in a great text of for a colleague or a team that have gone above and beyond. I know that's the highlight of BG's week in terms of receiving that report every Friday afternoon. And then that's fed back to the team or person that has the great text put in for them.
Very good, very good. Any more for any more? That's been a really productive story. As usual, I'll send a card on behalf of the board to both of them actually, so if you wouldn't mind sending contact information to my office, that would be helpful. The focus on the small things, the focus on how this is a culture and a values story, the focus, as Hannah's picked up, that maybe not everybody always feels that when they've done something good like that, it's been recognised and picked up on, and therefore our need to just think about how we can use comms to push that. I'll bring you in just a moment, Bijou. That emphasis from Jeremy about the importance of spotting success, surprising people with thanks, I think is probably a greater power of any of us know if you've ever had anything to do with children. Recognising the good is much more effective than challenging the bad, and we'll make sure the board walkabout gives us the chance to reflect on it. Bijou?
It was just to say there's another item on the agenda, 3.6, which will also, I think, pick up Hannah's point, because we will bring to board about the extension of the compacted behaviours that we are looking to sign off, and within that there is a line that is very much about giving back thanks as part of the Trust's commitment to our staff. So I think it just does all quite nicely line up.
Good reminder. Good. Joe, patient and staff experience, we get this regularly, and in some ways it's becoming pretty consistent, isn't it? So try and pick out where the change is, but if you can also, wouldn't mind, pick out that point, the learning from here, from the last strong.
Yeah, so thank you, Chair. So in terms of the patient experience overall, I think the very topic we've just been talking about is when we look at where our really strong performance is consistently through all elements of our care that we measure, either it be inpatient, emergency care, outpatient, stay case. What we see time and time again is really strong performance in relation to our staff and the interactions that they have with our patients, whether it be around involvement, decision making, etc. So I think we see that played out, and it's I absolutely take the point about how can we get better at feeding that back and ensuring that we're thanking our staff for that. In terms of some of the headlines, aside from that, I think if we look at our inpatient, both real-time and our right-time scores, we see strong, consistent performance. Where we see areas for improvement and focus to learn more and understand and get into the data to be able to identify those service improvement, policy improvement projects is particularly by site, is looking at our emergency care hospitals. So we see particularly around pain management, waiting for a bed. As an inpatient, we see that's an area for focus for us in terms of that improvement and around hydration. And I'm working with Chris Platten at the moment to look at that. We've done some deep dive into the data and we're looking by ward, so it enables us to work with individual teams, and we're meeting next week to look at an action plan for that. If we look at emergency care, again, both our real-time and our right-time scores, we perform strongly in the overall score for emergency care. We're in the top 20% when we benchmark ourselves against national survey questions for almost all of the questions. Our area for focus both in the real-time and the right-time, and the reason why we have two surveys and two methodologies in particular, that allows us to triangulate and to be able to really understand where we see consistency both at high performance and our areas for improvement. And we know for our emergency department in our emergency care hospital, it's waiting and pain management. And there is work to look at that. As Bijou said before, we don't want our patients to wait. So the Band 7s all have a delay each in the right time, in the real-time programme, and they all look at that individually and they have policy improvement projects around that. Included in this report is also the national maternity results. We were placed 50 out of 119 trusts. As an organisation, that's not where we would want to be, but if we look at our performance, it's stable, but for us we want to improve, and I'm working with Katie Listeman and the team to look at how we can focus in on some areas. Our staff experience, as Bijou mentioned, we had some of our best results in terms of the response numbers, and I would personally like to thank staff for taking the time to take part in the National Staff Survey. It's an opportunity to hear from our staff in a broad range of questions, and well done to NHFM who smashed it out of the park. And we're just in the middle of our local staff survey coming to the end on Friday. So we have our 3 key domains that include our NHSE questions. We've got, again, a good number of staff are choosing to complete the survey. We're over 4,000. We've also included, so we look at specific areas in which we want to understand more and improve. So we're looking at the Speak Up culture in the organisation, so that can inform our Freedom to Speak Up programme as well as our safeguarding programme within the Trust.
Good, thank you very much indeed. Let's save any comments on the maternity to the next paper when we've got the Maternity Champions report. Any comments on any of the rest of Jo's report? Kate?
Thank you, just 2 comments. One on the back of the response rate of the staff survey. It really felt this year that it's starting to be what we do around here. We fill in the survey because we get an action plan and things come out of it. So Bijou has 3 areas that we've looked at last year and we've really showed positive action on that. So it feels like a real cultural shift this year, which has felt good. And Jo and I have had some discussion about the staff experience programme because we've got lots and lots of data. It's what we do now with it and whether we start to target a bit more specifically, do one thing well rather than trying to do lots of things okay. So we had a development session by PCC on that, so we'll look to develop that through this year.
Good, okay, and without wishing to be competitive, 74%, how does that benchmark?
The highest.
The highest, that's always nice. Good, okay, thank you. Any other points or questions to Jo? Then can we move on to maternity? Plenty of positive stuff, but also that recognition. Actually, I'm not sure if it's 50th or 58th, but either way, it's not where we want to be on the maternity survey. Margaret is the chair.
Thanks, Chair. Yes, it is 58. But just following on from Jo's report, one of the things when I looked at the patient survey, Ward 16, which is the postnatal ward, actually was in the top 10 for satisfaction. So there's a little bit of disparity across the board of the maternity services there, because we've got 9.67, but we do have a problem. So I'll start with that first and then I'll go on to the maternity. I think the team were incredibly disappointed when we got the report, as Jo said, and it's great that Jo is working with the team right across the team, trying to understand why we didn't make those movements that we should have done at that particular time. We just more or less stayed still. I think we had two of other questions where we had a slight improvement and one where we'd actually made a deficit in that, which was really quite concerning. But what was fantastic to see was that the maternity team very quickly set up an action plan, started to talk to you, started to understand what do we need to do to really get us back into that position, because we were 23rd last year, so we've moved from 23rd to 50th. And I think what was very disappointing to me was in the region, we were number 2, and we've gone to number 7. So again, not good, and the team know that. So I think it's about how we work together, how do we instill what the values are, how do we actually make progress, and where do we actually improve on our service improvements. So just to assure people that it is in hand. We've done a number of things that we've put in place already around that. We've got a new deputy head of midwifery starting next week, I think it is, and we are hoping that we will be able to really showcase what a good service it actually is.
And some of the issues and actions are being considered at the private board this afternoon.
Yes, absolutely. So just sticking with this report is to just give assurance that here as a maternity safety champion that I actually am doing exactly what I'm supposed to be doing and meeting the national standards. So I'm not going to go through all of it, but it's just clearly identifying you where I am, where I go, what I understand about midwifery and obstetrics and special care baby unit as well, because that's part of that patch. So there's been a number of meetings, and the most fantastic experience I get is when I am able to talk to users of the service, and particularly new mums. But it's quite difficult because they often are not in hospital that long, which is absolutely brilliant because they're getting really high quality, good care. But when I have, and I did it the last time, it is fantastic to hear the service, and they really do wax lyrical, which doesn't necessarily sit with what our survey was saying at that particular time. So we've done quite a few different issues, but I think what has been interesting this year is that we've really started to look strategically at what changes are required for that service. It has grown substantially. One of the largest maternity units in the region. I think in this afternoon's meeting, private board, we are discussing a number of those areas strategically, particularly around home births, particularly around culture. One of the other areas that, because this report was done just before Christmas actually, was around how we support our colleagues within the maternity unit, and certainly the newly qualified midwives that I've met on a number of occasions and the students, midwives, have really talked very positively about the experience, the opportunities. I think the team have done fantastic in developing a boot camp. Our turnover rate is pretty low in that area. Midwifery colleagues were concerned in the summer around fatigue and resource, and what we actually saw in September and October, a huge recruitment in that particular area. 23 new midwives joined over that latter few months. So you can start to see that recently, we've started to see a benefit that individuals are able to ensure that they're doing the training, that they're involved, that they're having times to do meetings and coming together. But there still is a number of issues around the multidisciplinary team, which I'm not going to go into at this particular board, around culture that we've been talking about for a while. But I think what has been excellent in the latter few weeks is that addressing of what those concerns are, and then again coming together across the disciplines, clinical and midwifery, to look at how can we work more closely. And certainly one of the things that we have planned to do as the quad for midwifery is a monthly meeting on culture that we've set up that is starting. Again, one of the things that has been very positive around the midwifery unit is our health inequalities, and how we look at, constantly looking at how can we support mums to be in actually attending clinics, getting the right support, and the opportunities of working in partnership with the local authority for various things that have been offered, and to the point where colleagues in other trusts have used the model that we've developed within health inequalities and poverty proofing, and started to copy that. That's including Newcastle and in Gateshead. And one of the other areas that we start to try to do across the Alliance is for the maternity safety champions and the heads of midwifery to get together. I wrote to my counterparts in Gateshead and Newcastle, I think it was just before Christmas, and I was hoping that we'd get a meeting in January, but I think it's going to be February now. So there has been a series of really positive activities going forward, and certainly, as I say, the mums and fathers that I've met have been, and grandparents, have been incredibly positive about the unit. But I do think there is a number of issues that I've put in here that I think we still need to address going forward. So
thank you very much indeed for that comprehensive report, Margaret. Appreciate that. Bijou?
Yeah, I think I just wanted to add to Margaret. I think we were all disappointed, including the team, about the maternity survey results. It's not where we would want to be, and it's not where we would pride ourselves in being either. I think the team have, Mary and Katie, especially with Elliot as well, have really focused in, shared the results with the team. I think the team were disappointed in seeing the results. I think the actions that have been put in place, particularly the recruitment, and the recruitment has then had a positive impact in terms of sickness absence in that area as well, should allow hopefully for a much better feel in the department now. And I think the team recognise that the stress within the department is reduced as a consequence. We have seen quite significant growth in maternity, our services being used here. So again, I think hopefully the increase in staffing and also the number of, or fewer vacancies that we have now will allow for a much more positive experience. And I think we welcome the opportunity to look at the next survey. Obviously, Jo and the team will continue to do the real-time information, not only from a staff point of view, but a patient point of view, to try and make sure that when the national survey is delivered again, we're in a much more positive position.
Thank you, Bijou. Any questions, comments? No, Marion, and then Jo.
Just one, thank you. Thanks very much, Margaret, and it's great to work with Margaret with that quadrant. I think we are very lucky about our student midwives, because we have met them recently and they all want a job with us. I think that's really good. Now, that didn't always happen several years ago, so I think the teams have really worked through that recruitment, and particularly the retention bit, because we have so many trusts around about us that are competing. We're all in the same pond, so we just need to be one step away. And I think with the culture stuff, particularly what you're saying, Veronica, we need to make sure from a cultural perspective we're on our top game.
Thank you, Madam Jo.
Yep. Yeah, so I'm just glad that culture's now been mentioned 3 times. Bill Kirkup came and talked to CPG, and I think his second report particularly focused on the importance of relationships between patients and the various teams all involved in maternity care. And I do think the patient experience triangulates some of the staff experiences going on in the unit. And that when we have new staff in, and there's been a change in the way the consultants work, and they're a much bigger team, which is great, that can bring challenges for the relationships between the various elements of the team. I'm really pleased that we're onto that, because actually I think with all the pressure and all the focus on, and rightly so, some of the technicalities of running a maternity service, I think that it's that cultural piece that really underpins the whole patient experience and the safety of the enterprise.
I absolutely agree, Jeremy. I think having Kit Carney now as the lead, clinical lead, has made a big difference in some of the issues, but that's quite new, isn't it?
Great. Well, I think we've received assurance on the process, on the role of the champion and the gathering of the information, the triangulation of evidence from different sources. And I think we've received assurance that although the data is not giving us the story that we want, that we're firmly on the case through a lot of different ways, and some of the detailed ways we'll be exploring later on this afternoon. So I'm about to move us on from the maternity champions, with thanks to Margaret for that. And we're into our normal non-exec board walkabouts. We've got 2 of them this month. First of all, Steve and safeguarding team, you've taken over as safeguarding lead for the board, so good opportunity to look on and visit the team.
Yeah, thank you, Chair. It's a good opportunity, as you say, as taking on that safeguarding lead role, but also because the team have just recently shifted from a building that you can just about see from the window behind you to Cobalt. Hope, and I think the safeguarding team hope, that we use some safeguarding language, this will be their forever home, because I think they've had a bit of shifting around, and it's an important function to make sure everybody knows where they are and how best to access them. With that in mind, the only problem I think with moving was they've moved from their busiest site. So I think there's a lot of sense in them moving to Cobalt, but they're really quite keen to have a dedicated space in the main prominent site to conduct some of the work, and also act as a base to do the regular walk-arounds that they do, keeping in touch with wards all the time on a proactive basis. That's a really important part of what they do. I had a really useful period of time speaking particularly with Kirsty as our safeguarding lead, and clear that there are some challenges in terms of capacity, and it is a big team, so that there are some circles to square there, I think, going forward. They do an awful lot of really important statutory stuff, providing supervision and excellent training resources for all of our team. So I think that's really important to recognise as the trust grows, that demand grows. But there's also a huge information requirement. They have to supply information and sensitive data to a whole range of bodies and forums. I've mentioned a couple there, whether it's MASH or MAREC, or the Agency Risk Assessment Conference, that is. And these are, as you know, Chair, incredibly sensitive and difficult processes to manage, and you really do need to be on top of your game and supplying data into those systems. And it feels like we've accumulated more and more responsibility for being the home or the provider of that data. And I just want to recognise that there is a risk in that we just become a fallback position as the other parts of the public sector struggle to deal with demand of safeguarding. So I think that's one thing, just constant supply of data that's required. IT obviously is going to be one of the solutions, and they were very complimentary about the new OneView system, moving from System 1 as a way that's avoided some duplication, as they would see it. So that's very welcome, but I think that will only take us so far. I think there's some opportunities going forward about how we work with our local authority and police partners in terms of having clarity over whose responsibility it is to provide certain levels of information.
Okay.
Of course, it's not all about data and the real practice stuff. I've given an example there of some really detailed and difficult circumstances that a patient has been facing and consequently has landed on our doorstep numerous times, and the real sensitive approach that the team have taken to not just reduce the frequency of attendances by that person, but having a really consistent approach so they can understand how they can best interact with the health service and get their needs met. So I was really impressed with that. And just looking ahead, I think they've got a real idea about prevention, looking ahead at the 10-year plan, really getting to grips with some of these more difficult and as they might be called frequent flyers, people attending quite often, bringing a lot of challenges to our sites. And that seems to be funded quite ad hocly, I would say, and there might be ways of thinking ahead about how we deal with that as a system with our local authority partners in the future, I hope. And finally, just the opportunity to really get a grip of that is the safeguarding strategy. It's due for renewal in April, and I would really think that it's a good opportunity for us to take a step back and address some of these capacity issues.
Thank you. I think that's terrific. I was involved in setting up MAREC 22 years ago, I think it was, and it wasn't intended that it would be driven too much by one individual agency. It wasn't that, not quite the picture. As we move into the IHO discussions, is this within scope, looking at the safeguarding partnership arrangements?
I think that part of it is, there is a requirement though in terms of the statutory responsibilities of the commissioners around safeguarding as well, so I think we just need to be mindful about what we'll need to stay with what will become our strategic commissioners versus what we'll be able to influence from an IHO point of view.
Okay. Good. Any questions or comments? Steve's really interesting report. Jeremy?
Just to say that the team are an absolutely critical resource to the way healthcare runs in this day and age. There has really been, over the last 5 to 7 years, a big change in the vulnerability and needs, both from a mental health and a social care perspective of the people who visit sites with lots of complex sections. I'm going to have to talk to Bijou about a case that's just going on today that we share with St George's, and it is really tricky territory to navigate, and they've become an absolutely key part of that. The team has grown, but it is, and we're no different from, this is all going on in primary care, mental health. it's really.
Kate? Yes? Sorry.
Just to echo Jeremy's points with staff as well, and safeguarding have been really pivotal to HR, and they sit right next to them as well, and we've got a really, really good relationship with them, and very involved in what we do as well. So just to echo Jeremy's comments.
Where will the safeguarding strategy go? Will it
Go to safeguarding board.
safeguarding board, and then will it come to safety and quality?
Yes.
Yeah, okay. We'll decide whether we want to actually see it here or whether we'll have done it through those mechanisms. Good. Thank you very much indeed. Then let's move on. Katie, you've had the joy of going to Osprey. That's always is a joy, isn't it?
Yeah, it is a huge joy. So I went to Osprey last week and just loved the few hours I had there. Focused on the community hospital and also the community nursing team. The community hospital, I mean, it's beautiful. It really is, and just the way that the residents have that independence and that care is just wonderful to see. It was really informative actually. It was taken through particularly the assessment process to ensure the residents are appropriate for Osprey, which was great to hear the diligence that they go through. They're doing an awful lot to engage with the community around Osprey and around Northumberland, making sure that the residents there get out and about and enjoy themselves and retain that independence, which a lot of the residents I spoke to are really pleased they still have that level of independence. Looking around the facilities, we looked around, there's one room which was empty, and it was like a hotel. In fact, you get Prosecco. It was quite something. But yeah, well, I was tempted to say. It was just lovely to see how they've taken that clinical edge away from the rooms. It's just so welcoming. Speaking to one of the residents, one of the residents who's been to the golf course that morning, just come back for a hot scone, he was offering his lovely lunch. It was really great that they're getting the care that they deserve and they need, so that was lovely to go through. With the community nursing team, again, it was lovely back to culture, but it was lovely to hear the cultural change across the last year in a positive way. So it's much more unitary rather than being allocated to primary care networks. They're feeling like they're working as a whole unitary team now, which was lovely. They started to really try and improve the accuracy of their data, so clarity on the number of patients they see, have got them now and understand the district nursing place and picking up on those calls that they get during the day as well. So it'll be interesting to see when they've gone through that trial just how that's worked. And a lot more clarity on the information on how long these visits take, so we can really start to see if the workforce is appropriate for an ageing population that want to stay at home. It's also good, they've picked up a lot of their issues with System 1 and IT issues, and that's been listened to and acted on, so that was great, and they were really pleased with that. So it was a lovely visit. I mean, I noted just a few potential actions at the hospital. They were asking if we can support with training as well, which I know Philly was taking that forward. Again, access to outdoor for the residents at the hospital. It's going to be difficult to do some extending to it, but not every resident is able to get downstairs. So it's thinking that through. And then any ideas, I think every resident hates bingo, so any ideas that we've got on what else they can do in the community would be great. But yeah, wonderful.
That's terrific, and as usual we've got a few action points which we probably don't need to take at board, but because they've come in through the board walkabout, there will be proper responses.
So we discussed with BJ at the last walkabout how we after the last meeting about how we get feedback from these walkabouts back to the units. So what we'll be doing now as a process is we'll share the walkabouts originally with the lead exec, the business unit director, and then the member of staff who's shown them around, and then the reason we've asked for those potential actions is that we'll then agree those actions with the relevant executive and business unit director and create an action plan for the board that we can then monitor so we can see the real feedback from these walkabouts at ward level.
Thank you, and a reminder to note you complete these board walkabout reports where you name somebody, I send a card after the board to acknowledge their contribution. But when you name them and are complimentary about that. Good. Any other comments to Katie? Then thank you. Let's move on, and we've been joined by Patrick, the Freedom to Speak Up report and the strategy in action. Patrick.
think Joe's actually going to speak to
Oh, sorry, Joe.
Yeah, we've got a double up for this one.
Yeah, fine.
So we brought the dashboard for the Freedom to Speak Up programme for the previous 2 quarters. I think reassuringly for us, we're seeing a steady but small increase on the number of cases coming forward, so we would always welcome that our staff come forward. So I think in part we think that might be the introduction more lastly of our new ambassador programme. So we've built on our Freedom to Speak Up Champion programme, and we've now got in excess of 40 ambassadors across our patch. And we have noticed an increase, and it was very much about promoting the role, promoting people to come forward, so we're starting to see some of the benefits of that programme very early on. Again, we're very reassured that out of all of the contacts we had during those periods, there was just one anonymous contact. So all other members of staff, without exception, just to that one, were happy to be identified with either Patrick or myself, or in some cases both of us. And that helps us to be able to help staff in the best way possible. Just on half of the cases altogether, thematically, were related to staff wellbeing and safety. We talked about this in PCC yesterday. It's a catch-all, so it can include a wide range of things. So what we thought would be helpful to board in PCC going forward, because this is the National Guardian Office framework that we're using in the dashboard, is to start to subdivide those, so board and PCC get a better sense of actually what does that relate to, for such it being the biggest proportion, and the others will subdivide. In terms of some of the learning that we take thematically from the people that Patrick and I have had interactions with, we've talked about it already today, but culture, so how important culture is, particularly at a team level. And the impact that can have on our staff, and sometimes that can be the reason that they come forward for a variety of reasons. Environment, the working environment, in terms of people needing reasonable adjustment, if they have a long-term condition or a disability. Feeling involved, and I would say, particularly through my own experience with the people that I've met, it's around ensuring that it's effective involvement. So sometimes we may feel we're involved, but actually has it been effective for a member of staff or a group of staff. And worries about change through coming forward, which we hope Patrick and I would hope that we allay that by the time we get to the end of the process, because we absolutely make sure that it's a continual feedback process and our door is always open after that.
Very good. Patrick, anything you want to add to the dashboard? Or just saving your fire for the strategy?
No. I think that's all probably covered.
Good, Bijou?
I just think this is a really positive dashboard. It's taken a little while for us to get there, but I think that it absolutely clearly shows where we've got issues, what's happening in terms of how we're sharing that learning, and then breaking down. I think that I'm comforted by the fact that we've only got one anonymous this quarter, because I think that, or quarter 2 and quarter 3, because I think that's part of the culture we wanted to promote. We want people to be able to speak up and not be afraid to speak up, and I think that is a proxy indication of that. And I also think that the split between, you have a large number of contacts, but actually those that are freedom to speak up and those that aren't. And I think, if I'm correct, but please do correct me if I'm not, Joe, that on the non-FTSU cases, there is still an element of support given to those people, be it signposting or something else. Nobody's left without knowing an outcome of their query.
Absolutely, Bijou. It's treated in exactly the same way, but in terms of it generally is giving people signposting or support. It's just a slight. It's not classed as a freedom to speak in terms of if we think about what freedom to speak is, but we get just as many staff coming forward to ask for support or help with signposting.
Very good, Maria.
Thank you, Chair. Thanks for the report. I'm wondering about those non-freedom to speak up questions, specifically around cancer diagnosis and support. Something is niggling there that says that perhaps there's variation in the way that some people are supported. So presumably that would imply that some teams where you have somebody who's in leadership that is very supportive, others might not experience that. Likewise with other things like reasonable adjustments, etc. So that there's something there, there's a signal there about variation in the way that people can access those things, and also their awareness of what they're entitled to, what can happen. And I'm just wondering, is there a way of addressing something as a separate piece around transparency around some of those issues? Because I'm presuming it's not going to be just one person that experiences this, and cancer is just one thing. There are other dread diseases, chronic conditions that people might need support around. So I feel that this is an opportunity where we can do something more broadly for staff.
Yeah, I think that's a really good point. I think absolutely we should look at that. But also in the case of that one, the individual is happy to be identified as going through the process and actually fed back to the people concerned. So that as an individual case, Maria, that worked in terms of, but I think you're right, looking at it overall.
Patrick, do you want to add?
Yeah, I think that might kind of be reflected in the report that I'm doing around the workforce disability equality standard, because one of the areas that we're looking at developing is some resources around reasonable adjustments and supporting staff and managers to make better decisions about that. So.
Delighted to see no reports of people experiencing detriment. That's hugely positive. And overall, this feels like we've settled this down. You know, there's been slightly rocky periods, but this has really stabilised, and it feels like evidence and data we can rely on and use effectively.
And I think the other bit that with the champions as well, the board reflection tool, the outputs of the board reflection tool, we undertook that exercise as a board about what our model should look like in the future. I think that's really helped as well, and actually I think it's paying dividends now.
And I'm assuming that the draft strategy was attached has been chewed over by people and culture. So, yeah. What have we been asked to do with this today? I mean, we can note it, and it was from a year ago. Is it just to kind of remind us of where we are?
Kind of to approve it, because we made a couple of changes based on the requests from board and from PCC around just strengthening the trust commitment to an open culture. So that's in that first paragraph that's been updated. I think there were one or two small minor changes we made as well. So this
Thank you. I couldn't see the changes as maybe just the way the paper was formatted. Are they not significant changes?
No, they're not significant.
And people and culture have approved them?
Yeah, we approved it yesterday.
Okay. Are people ready to take it on that recommendation, or do people want any further discussion on the strategy that people and culture have approved? I think we're happy to receive that. Then thank you, and well done, and thank you to Patrick and Joe for the continued leadership of this important service. Good, and Patrick, you're still on now. We've got some challenging issues here with Les Des.
Okay. So normally, I'm just going to assume that people have seen the papers and kind of like that, if that's okay. Normally we've been doing a full equity and inclusion dashboard, but we updated that in September, and we can't update it again until the embargo comes off the National Staff Service, so that will be done along with anything that comes out of this current staff survey that we're doing now as well. So we're focusing on the res and the des from 24-25, and normally we would get a benchmarking report, but this year the national team didn't send out benchmarking reports. The data has just had to be taken from model hospitals, so we've done that, and we've kind of done a full analysis of all of the data. So this is just kind of the highlights, really, the bits that we need to pay attention to. We had a look at some of the specific actions from the previous resident des kind of outcomes and staff survey around doing a deep dive into some of the core experience of our disabled and long-term condition staff, because that was something that we've been asked to look at as well. So as well as the resident des data, it's also incorporating some work that we've done in engaging with some of those staff in the trust who've got long-term conditions or disabilities. In terms of the disability equality standard, the declaration rates continue to rise, but we know that there's a gap there between what's declared on ESR and what we've got in our staff survey results, so we still need to do some work on that. Overall, the experience was positive compared to national staff survey picker average across nearly all of the metrics that we measured. Particularly positive around harassment, bullying and abuse, and the reporting of that. That was pretty even between disabled and non-disabled staff as well, which is fairly good. The sense that people felt that the trust offered equal opportunities, and that people felt valued in the work, and that we scored very highly around making reasonable adjustments, which is a very reassuring thing to see. And also we've now got kind of an increasing number of people on the board who are declaring disability as well, so that's reflected high in the staff count on the ESR. So in terms of actions from that data for around disability and long-term conditions, we need to kind of reduce some of the disparities between disabled and non-disabled staff, because even though we seem to be doing better than our peers, there are still kind of gaps between the experience of disabled staff and non-disabled staff. We want to work on keeping those declaration rates increasing. We're going to do some kind of work with the local trust that have got a high declaration rate to see how they've managed to get people to complete their demographic data. Again, in terms of spread of staff across the different grades, there's a disparity between disabled and non-disabled staff at any grades above A, B, and C. So we want to look at that and how we can look at the kind of career progression through the grades. In terms of the work that we did with disabled staff on engagement, one of the very strong themes that came out were around reasonable adjustments and support for managers to understand reasonable adjustments and how to access some of the support systems either within the trust or outside of the trust. So one of the things we're looking to do is develop some resources that go on the staff portal that will be about self-help for the staff themselves, but also can support managers as well around training them to be better at kind of acknowledging and supporting staff and make reasonable adjustments. And again, based on all of the previous surveys when we've asked questions about long-term conditions or disabilities, the highest percentage have been staff with a mental health issue. We know that's reflected in our sickness absence, so there'll be a focus on how we continue and kind of increase support for staff who've got mental health support needs as well. In terms of the workforce race equality standard, again, numbers have increased. We've got 10% group of staff now within the trust who are non-white British, which is much higher than the local population. Again, compared to our peer averages, the overall experience is positive, particularly around harassment, bullying and abuse and discrimination from patients and from staff as well. People feeling that we offer career opportunities and equal opportunities for development, and also board representation has increased as well, so that's kind of just above the amount that we've got on ESR. In terms of the actions from the data, one thing we really need to do is to look at that disparity between the scores for shortlisting to appointment. Now we know that that's been an issue that we've focused on over the last year. There's some significant work going on with our kind of recruitment team to try and understand that and to try and reduce that kind of disparity. There's been a fourfold increase in applications from non-white British kind of applicants, so we understand that that's similar in other trusts and they've managed to reduce that disparity, so we're going to be doing some joint work with our partners across the Alliance who managed to do that. Also, we need to reduce the instance of kind of discrimination from patients and from fellow staff members as well, because while it's better than the peer average, certainly there's a gap between the experience of BME staff and white staff in the organisation. And again, when you look at the figures for distribution across the grades, although that's improved significantly on non-clinical, there's still a gap between kind of some of the higher grades in terms of percentage of people in those roles. On the clinical side, it's almost the opposite way around. So we've got a very high proportion of BME staff who are senior clinicians. In terms of other actions, we also did a piece of work with our network staff. So we know we need to do some work on reinvigorating the networks and getting some more involvement. And also we're looking at an internationally educated clinical staff as well. We've got an interview process going on at the minute. I'll be involved in trying to get somebody to support staff who are coming in trust from abroad. We're going to be doing a lot of focused campaigns that are going to profile some of our really staff who've made progress through the organisation and have kind of got really positive stories to tell, and some kind of targeted campaigns around addressing racism where that becomes apparent. We've already started to measure that on our freedom to speak up issues if there's a race issue there, and we've also started to measure that on our letters that we send out to patients as well. We haven't seen a significant increase even though some of the local trusts have. So again, we've got some training programs going on at the minute, and that again will be rolled out via Calidus as well as it's being offered as part of the experienced team offer. So if anybody's got any questions or suggestions about what else we could do, that would be welcome.
Patrick, thank you. Just to remind ourselves of our role here, I know again people in culture have had the chance to dig into this effectively. So to try and restrain our desire to go into too much of the detail, I think we need to assure ourselves that there's a rigorous, robust, evidence-driven and energetic approach to the issues that have been picked up by the data that we've got, and that we've got systems in place for moving forward on those areas. I don't think we can be fully satisfied with the outcomes of the data. At the same time, I've got quite a lot of assurance from that presentation that we're tackling as far as best we can on that. But Katie, anything from P&C, and then I'll bring in Maria, and I think Kate's got it.
You summed it up perfectly. We went through in detail yesterday, and it's clear that there are disparities, and we want to ensure that those are reduced. So we were very comfortable with the actions that are in place, and that will be monitored through PCC to see the impact of those actions.
Thank you. So the real question is, what more? Anything else to get? Maria?
Thank you for that presentation. I just wanted to ask that going forward, that we have assurance that the staff members that are part of those cohorts, that there's transparency around their involvement. I know that there's been involvement around the people experiencing disabilities, just making sure that there's always transparency around their co-production of whatever modes of improvement are taken on board.
Yes, absolutely. That's part of our remit, to try and kind of reinvigorate the network groups and kind of engage with staff across all the different protected characteristics.
Okay, so let's capture that in the note as well, the other area of assurance. Kate, anything final?
Yeah, we had a really good challenge yesterday from a member of PCC that said, so what are we doing today about people that are feeling like this?
Yeah.
Because these are quite medium to long-term actions that we've got in place. And we talked probably about two areas, so that encouraging to speak up, whether that's by your line manager or through the service, but also the key is your line manager. It's that line management training, it's the confidence and the relationship you have with your members of staff, and we need to really keep plugging that, so we're looking after these people.
Thank you. Are we feeling sufficiently assured on the processes and content? Yes. Yeah. Thank you very much indeed. That was a terrific presentation, Patrick, and Joe, for yours as well. And the final one under this section of patient and staff experience, and to note we're running a bit behind, staff flu vaccination campaign update. Is Nicola? Oh, I'm so sorry. I'm so sorry. You tiptoed in behind me. So, yes.
Good morning everyone, I'm Paul Constable, Head of Occupational Health and Wellbeing Services. So update on the vaccination campaign. So nationally our target this year was 62.4% for frontline staff, which is 5% higher than what the target was 5% higher than what each organisation achieved last year. So we're currently sitting at 62.6%, so we're slightly over. We're hoping to get that a little bit further, although we will be stopping the hubs and the roving on the 6th. Staff can still come forward, so the communications have gone out that anybody that still wants to get vaccinated can be vaccinated. For organisations that are of similar size, we are in the top 3 for nationally. So we do acknowledge that obviously that percentage is somewhere where we absolutely need to increase, and we need to continue working on that. And we've already started doing our reflections for what we want to change in next campaign. So this year we introduced the peer vaccinators, which has been really good. They've accounted for 12% of the vaccinations that we've delivered. We want to increase that percentage next year, and obviously be very mindful of the efficiencies that we need to make. We also want to work on our communications. We're working with public health colleagues around those hard to reach groups of people, especially the young and fit. And we also want to make our reporting a little bit more efficient, but we will bring a bigger piece around our reflections that the next time we're invited.
Well, that's really good. This has been a topic of high priority for the board. We managed to demonstrate 100% sign up as a board, so but I'm delighted then that our target has already been exceeded, but you're looking to move on. Shall we wait until we get the reflections paper, so to have the more detailed discussion as to how we can do even better next year? I'll take any questions and comments now, but maybe we'll save the big debate for later. Are you happy on that basis to receive and congratulate Nicola and her colleagues who've done a good job? And we all know this is not just a matter of ticking a box, this is a matter of helping us reduce staff sickness and important for patient outcomes. So really grateful to you and your colleagues.
Thank you, and thank you to all the business units and everybody who supported us. That's been really helpful.
Thank you. Very good. Thanks very much indeed, Nicola. No time to sit down. Johnny, because you're on right now, we're into the next section, performance and strategy, and we've got a couple of business unit updates for us to dig a little bit into how things are going in two of the business units. We've got child health, and then we've got clinical support and cancer services. So Johnny, kick us off with child health.
Okay, thanks very much. So you probably will know me, but I'm Johnny Cardwell. I'm a community paediatrician, business unit director for child health, and Anna's come along as well as deputy business unit director, and Paul, who's doing some of the presentation as deputy director for child health. So just a quick overview of the services that we provide. We have about 340 staff in child health, a budget of just over 23 million. In terms of services, we provide services at NSEC in terms of the paediatric ED, acute paediatric, short-stay paediatric assessment unit and special care. But we have a lot of community services, including mental health services, so it's just to say that really. Provide a Tier 3 CAMS service in North Tyneside and Tier 2 CAMS in Northumberland, private mental health workers and school-based emotional support CAMS. There's around 34 staff in that team. And another group is the school age immunisation team, which has a huge number of contacts with children, young people and families in Northumberland, Newcastle, North Tyneside and in Gateshead as well. Probably around 100,000 contacts over the course of the year. I'm going to let Paul's going to talk about some of the performance and the next set of slides.
Paul. Thanks, Johnny. So just wanted to share with you some of our patient experience and information. So you can see generally there we have good strong performance on the children's unit. One of the dips on the graphs you'll see is around the food element, which is part of Sophie's legacy. We've worked very closely with the catering department to help improve that in terms of the offer for children and also for parents as well, visiting the patients on the ward as well. And the bottom bit just is around SCABU and the kind of satisfaction in terms of the rating for the service as well from all our patient experience feedback as well. On the next slide, it just shows our outpatient survey report. I'm not going to go into all the graphs, but a couple of things to pull out on there are the second graph at the top. Some work around inequalities. We've got very varied results on that area, so making sure that we are talking to patients, to children, to families around any inequalities and how we can help access and support those children and families a little bit more in terms of the future, and also just on the table at the bottom right as well. The areas towards the right hand side in terms of children being seen alone has a strange score because we give children the option of whether seen alone or with the parents as well, and sometimes it's a bit of a combined appointment where you see the child and the parent comes in later as well. So a bit of work to be done just to be clear on those areas in the outpatient work. The next slide is our staff experience slides. As you can see, we map just above the trust average. It's the key message from this slide. We sit just above the trust normal. We've seen a month-on-month, a survey-on-survey tends to rise very slightly in terms of our performance measures and that. So we're very comfortable overall as a business unit. That's not to say we don't have challenging areas within the business unit, and we do bespoke work as needed within those areas to help support and develop staff and teams as we need to. In terms of workforce, we've had successful recruitment for consultants, clinical educators, roles both across the community, acute and community paediatrics as well. Specialist nursing teams, and these have been a real kind of bonus in the last year, I guess, in terms of the specialist nurses with skills for our outpatient clinics, targeting our key areas around epilepsy, diabetes and allergy as well. We've recruited further into our, they're not called ANPs anymore, they're advanced paediatric clinical practitioners and advanced neonatal practitioners as well into Cebu. So we've had investment in those, which has helped support our rotas and teams alongside the medical staff as well. And we just see the impact of those. And we have a strange Cebu unit where it's probably more advanced practitioner-led as well. So we've just appointed 2 new consultants into paediatrics as well for the acute team. ED performance, the graph on the left just shows us in terms of the trends, so you can see this year was higher than last year, which we normally see year-on-year increase, and that's at 8%. In terms of the graph on the right, our ED performance does look very seasonal in terms of the winter and the summer. This winter has been difficult, in terms of the numbers seen, and our performances did below where we were last year. We're doing a really focused bit of work at the moment to get us back up to where we need to be, covering off lots of different elements within the paediatric ED. We've got a bit of a strange model because of the staffing model between the paediatric ED and the ward as well, and how we can be more efficient between the 2 areas as well. But that's, and we're linking in with the improvement team as well to help us just put a bit of structure around all of the work we want to do, because there's several different strands to this to help improve our performance. And again, the graphs there just show our outpatient performance. You can see we do well in terms of the graph at the bottom, we do well in terms of our performance against the 18-week standard. But you can see the graph at the top, we do have increasing referrals coming into the service. We're managing to keep on top of the demand at the moment. Although the waiting list size is increasing slightly, the table on the left, but we're managing that through our outpatient team and managing demand as best we can. And I think the final performance slide, so yes, this was around in terms of all the different areas that we've progressed into. At the bottom bit is there our quality panels as well. So you see we've had good and outstanding results from those. 15 steps have been really positive on the ward as well. And we're looking at our waiting times in neurodevelopmental pathways. That's linking in with work with an external contractor as well to help us support those waiting times as well. So doing a lot of targeted work around maintaining our performance. Johnny, it's over to you.
Thanks. So one of the focuses over the last year, and probably for a little bit longer, is around inequalities and tackling some of the inequalities or the impact on access to different services that we provide. Sophie's Legacy, as Paul mentioned, that was we had some funding from that which supported provision of food for families and children, siblings on the unit at NSEC, and also some public transport costs if needed. And some of that's being continued with some money from the Bright charity for next year as well. Poverty proofing, it's a wider initiative I think around in the organisation, but in CAMHS it's been looking at specific pathways and things that we might be able to change to improve access and engagement in some of the pathways that CAMHS provide around digital access and those sorts of things. Trying to understand why children aren't brought for telephone appointments and why children aren't brought for face-to-face appointments. Those are important bits of work which are going on at the minute in the department. There's been improvements since I last presented. I couldn't quite remember when it was when I was last here, but I think I mentioned at that point we were starting this called Connecting Care for Children, or Children and Young People's NDT, which is part of that wider NHS neighbourhood initiative, part of a 10-year forward plan around localising healthcare outside of hospital settings largely, and trying to work more collaboratively with other partners and agencies. So we've set up pilots in Blythe, which has been going for about 6 months I think now, and Anna does that pilot, and we've started one in one spec which I do, which is evolving. And we've discussed quite a lot of children within those different MDT meetings, and I think have certainly found different ways of providing care in a more coordinated way for those children and families. There's been some further recruitment to the primary mental health worker team in Northumberland, with the ambition that all the different school partnerships will have mental health support workers in place by 2029. Our paediatric epilepsy nurses are now doing paediatric clinics, seeing some new patients alongside consultants with interest in epilepsy which has reduced some of our waiting times for that and the prescribers too. Again, last time I think Joe's here, we were talking about wanting to establish a Children and Young People's Advisory Group to help us in terms of contributing to the development of our clinical strategy, because we can have the voice of children and young people. So Joe's been really helpful, and in terms of scoping out what that might look like in discussion with the Newcastle group, which is already established, and one in Sunderland in South Tyneside. So hopefully we will get something more formulated, I think, and up and running within the next 12 months. And we had the first World Cafe for children and young people around transition as part of the lifelong strategy group that happened, I think, November time last year.
Last couple of minutes.
Sorry.
Last couple of minutes.
Yeah. Move on quickly. Digital Badginet's up and running now in Spoo, which is great, and the services are using that well. I think I'll perhaps just move on. I've shown you the slides of the estate before, and it's Meadowell this time that we're working on in North Tyneside as a children's outpatient suite. I think in terms of the business unit, working really well. We've got some great staff. We had our away afternoon yesterday where we were doing our thinking about our annual plan in the context of the 10-year forward plan, and we had lots of presentations towards the end of that around achievements that we'd had over the last year. Quite a lot of stuff there from the immunisation team in particular, doing lots of great work around some of the health inequalities and access to certain groups of the population that perhaps don't access healthcare in the same way. But I was really impressed with the commitment, I think, of the staff and the imagination of the staff that we have within the business unit. Pressures around EdSec continues to be really busy. It's not getting any quieter. More children are coming to be seen there. We have to manage that, and we see an awful lot of children being referred for consideration of autism and ADHD as we have over the years, and that's now in the preschool age range as well, and that creates quite a lot of challenges in managing those waiting lists and waiting times. I'll leave it there.
Johnny, Paul, Anna, thank you very much indeed. Really clear, really helpful to make sure that we're up to date with developments. Any questions, comments, challenges? Yes, Margaret, and then Richard.
Thanks for the report, really good. I'm just really interested around the advisory board for children and young people, because many trusts actually already have these set up, so just a little bit more detail on that. Why have you not had one before?
We have had, well, we had one, it was quite a few years ago, well before COVID, and we had one established down at North Tyneside when the paediatric unit was there. It worked well. And then, I suppose, as things happened, staff moved on, the group of young people that were involved in that moved on. It didn't continue in the same way, probably challenged as well by COVID. And so it's about, I suppose, because it's reinvigorating that, it's restarting that in a way where we get a cross-section of children across the whole of our geography, which we didn't have previously, and that is a challenge, I think, to get the whole of Northumberland and North Tyneside involved in that. There's something about doing it face-to-face which is much better than on Teams, and also making sure that the children and people get something back from it as well, I think, for their own development.
It's good though that you're working on that, because we've been flagging up that with governors, however effective they can be on engagement, they don't bring the children's voice. And,
no, that's right.
So really, I'm really glad you're pursuing that. Yeah. Richard.
So one comment and a question. Comment first of all, I've watched the immunisation videos and I think they're really clever, so well done on that. They were superb. Question, I guess, because we've worried about it at the board a number of times over the years, has been the boundary at Norfolk Children's Hospital and whether the 23-hour model needed tweaking. Just interested in how that's developed since your last year.
So there was a lot of discussion and looking at the different units in Gateshead, in Newcastle, and our unit in North Cumbria as well. I think at the moment, after all of that discussion with things which are continuing to go on within Newcastle, it's not the nature, the designation of our unit's not changed. And the inpatient bed capacity in Newcastle for general paediatrics is definitely challenged from just Newcastle patients, but also south of the river as well. So at the moment, those conversations, I suppose, in fairness, are probably paused in terms of redesignating what our unit is, and we're trying to manage with the workload that comes in. We continue to keep some children, as we always have, slightly more than 24 hours if they're getting better, and the care is continuing to improve. But the underlying sort of practices, if you need ongoing inpatient care, we would transfer to Newcastle, but it is a challenge.
Yeah, let's not lose that. We'll need to keep that inside. Thank you. Any other questions or comments to Johnny, Anna, Paul? Thank you. Really, really effective, comprehensive, and rather encouraging report. I think lots of good, useful, positive evidence. So,
thanks very much.
Thank you very much indeed. Rahul, welcome. We're running 10 minutes behind, just as a warning. I'm not asking you to find us 10 minutes, but I'm reminding the board that we're running a little bit behind, but that our next business unit, clinical support and cancer services.
Okay. So, firstly, thank you very much for inviting me to present today. Me and Paul will do this together. My name is Rahul Trimadikari. I'm the Business Unit Director for Clinical Support and Cancer and a radiology consultant. So our business unit has got multiple services under its wing. So radiology, which has various diagnostic modalities, pathology, hematology and anticoagulation, cancer, pharmacy, infection control, and the medical examiner's office. As you can see, and I'm sure all of you will be aware of the increasing demand on clinical services, and the figures kind of speak for themselves. We are seeing between 5 and 10% increase in the services we provide every year. Not only are the number of services increasing, but the complexity of services is increasing. So if we take an example of radiology, we haven't really massively increased the plain X-rays that we are doing, but we have massively increased the MRIs and the CT scans that we are doing. And another perspective is, previously a CT scan would have 20, 30, 40, 50, 100 images. Now it's not unusual for a CT scan to have 600, 700 images. So, so the actual complexity and increase is much more than what the numbers, provide. Cancer, meeting cancer targets is always a challenge. And we do put in a lot of resources to try and meet our cancer targets. We are near the top regionally and nationally, but I don't think that's something to be absolutely proud about or to celebrate. Our ambition really is to have this target at 100% rather than 85%. And I do feel that nationally, the national ambition of 85% is too low. For radiology, we do have excellent performance. So again, just to put things in perspective for you, these are if you look at the 6-week wait breaches, we have a monthly average breach of 15 MRIs per month, but we do 30,000 scans a year. So the numbers are very, very small. And again, we all, I'm sure, would like to have that as well. We have, there have been a lot of achievements in the radiology department over the last few years. We have a very regular equipment replacement program, and very grateful to Paul and Biju, the team, for supporting that program. We are probably one of the best equipped trusts in the country, and I think we are all proud of that. We are increasingly using AI in diagnostics, and I think we are just going to see that increase over the next 5 to 10 years quite significantly. So again, I'll not go through all of them, but we are doing a lot of work and getting a lot of support and introducing a lot of good things. Future plans, again, we have a regular equipment replacement program. We are at the moment working with procurement to replace our RIS and PACS, which is our information and picture archiving systems. We are, as I said, increasing in-house reporting. We are training radiographers to upskill, and our general ambition is to stop outsourcing of radiology reports completely. But we are still away from it. Paul will speak about pathology.
Yeah, thank you. I guess one of the key things to flag on the slide is that in terms of the activity Rahul mentioned as well, we are seeing some backlogs in our histopathology. Sorry, I thought I was on. Sorry, just to pick up on Rahul's point around activity, we are seeing some backlogs at the minute in histopathology, so we're getting additional staff in at the moment to help support with that and looking out for recruitment as well into those roles to help us get back on track into that world, but it is a consequence of all the activity that's coming through. I'll pick out the key bits on this slides for help with time. I think pathology transformation, we've done the first two parts of that in terms of the Wansbeck and North Tyneside side. NSEC is the next side. We're looking to go to a more automated track system that will have efficiencies across the way that the samples are managed when they come in into the lab from there. And just on the bottom of the slide, I put some of the highlights in there around our continue to maintain our accreditation that we have with UCAS. You had a really successful open day, which was well attended on Biomedical Science Day, to get people to come in and see the department and engage, because actually it's one of those behind closed doors departments, and people send samples off and don't really know what happens to them, so it was nice to get the teams engaged and understand further around that as well. Just move on to the next slide. I think within cancer, we've done a lot of work around the 28-day fast diagnosis target. We've now got some automated processes in place, so we can tell patients who don't have cancer, we can tell them quicker, which is a great piece of work, and it's linked to one of our SQ&I priorities as well. We've done some health inequalities work with radiology to try and help attendance for those appointments, so some of the poverty proofing work to make sure we can get people to attend for appointments, and to support the best way we can around times of appointments, travel, etc. as well. Some of the ED project work, we now have an ED navigator in place, and they are helping to support pick up patients as they come through the cancer pathway in that world. I'm conscious of time, so I'm just picking out some of the highlights, so I'll move on to the next one. Again, Rahul's mentioned about the 62-day standard. On the first slide we showed, we hit that in 5 months out of 14, but again, our aspirations is to be higher than that. I think the key bit to know around there as well is just our therapeutic treatments. Cancer treatments are changing, the time, the length, the course of some of the regimes as well, so that has a direct impact on our oncology day units in terms of capacity. We have managed to switch some clinics to oral clinics and do as best we can, but we are seeing that year-on-year growth. In terms of, in terms of pharmacy, we've just had our medicines optimisation strategy approved by the Trust. So this is about making population outcomes, making sure you get the right medication in the right place at the right time as well. So that's our next 5-year plan. MedChart moved to Nerve Centre in September, so that was a successful transition from one system to the other. And the ED pilot has been ongoing, so we've been doing that for a year around how can we assist more with ED colleagues, how can we work and help improve ED performance from the pharmacist. Infection control, I'll like to
So again, with infection control, small interventions can give us big benefits. So just pick up one out of this in the interest of time. So recently we changed the way blood cultures are taken. So instead of a single bottle to 2 bottles, what that allows us is to pick up more infections and different organisms. And that's a front-end intervention which does cost a lot, and we were well supported by Jeremy and the team in kind of implementing that. But it picks up infections faster and a broader range of infections, so the patients can be treated quickly and better, and at the back end it gives us better results. So a lot of other programs are going through infection control. I think some of the things that we are proud of in the last some time is that we have been able to attract more clinicians, be it radiology, hematology, or microbiology, or any other specialty. We are almost locum free now, which is great for the bottom line and great for the clinical outcomes as well. We continue to develop alternative staff and upgrade skills of staff so that they can provide a better range of services. So these are our key priorities for the next year or so. Use more technology, artificial intelligence, transform the laboratory, maintain our diagnostic performance, which is about 99%, and to try and improve our cancer performance to meet all the targets and go beyond, and review of the state and space utilization. happy to take it.
Rahul and Paul, that was a masterly presentation. Thank you very much indeed. Jeremy.
So, well done. I just want to comment, I'm going to ignore radiology and diagnostics. It's become the poster boy of support and is doing really well. But to just point out the acute oncology service that we developed at NSETCH and the patients that have been treated, I think that is something that is very necessary and is going to be expanded. And having some cancer services on that site in particular for the patients also presenting in the emergency care pathway, because not everyone is seen in those elective pathways that they're not quite doing 85% on. It's really, really vital. Some of the outcomes and the inequalities in that cohort. So I think that is going to be something we need to develop.
Joe, thank you, Joe.
Yeah, just to say we did some patient experience measurement actually quite recently, patients who accessed that service, and it was extremely positive.
That's great. Yes, Chris, and then Steve.
Just to pick up on the blood culture pathway changes and the fact, we won the Nurse Thames Award, which is great. Am I right in saying that then links back to finding more DKOIs or
yes,
and that directly links back to our enough rate? We're doing the right thing.
In other words, the more effective we are at spotting them, the worse our off-rating becomes. Gee, thanks, Rahul. Of course it's the right thing to do.
Yeah, we spend more money, but anyway,
Good point. Stephen.
Thanks, as everyone said, great presentation. I think the health inequalities work is notable. There's a well-trodden path across the Trust now of reducing DNAs and ozone broads and the like as some targeted ways to do that. I particularly want to congratulate on going even further, so there's stuff around prison inmates. That's not easy. Working in partnership with that sector is not easy, and I think it's a testament to your commitment to trying to reduce inequalities, that you're prepared to pick up that sort of challenge. Thank you.
That's great. I'll underline that, so thank you. Any more for any more? Rahul, Paul, thank you very much indeed.
Thank you very much. Thank you.
Let's move straight on to Winter Update, which has featured rather heavily in every committee, I think it's fair to say. So, Beth and Joe, welcome to the board. You'll be feeling well practiced in this presentation, and you can assume that everybody here has read through the slides and got.
Thank you.
Excuse me.
Thanks. So I'm Jo Hughes, I'm an ED consultant and Deputy Business Unit Director. I've got Beth as Deputy Director of Comments and Emergency Care Business Unit. Winter's so far started early, I think is one of the first things to say. So it started in October with increased attendances in our services. We had several days of over 450 attendances in the adults and high attendances in paediatrics, the one we've ever had in now. We have had high infection numbers from early October as well. Because of all of that, we had to open our escalation ward 8 earlier than we wanted to, so we have been monitoring very carefully about how we could maintain flow through the system. We felt that we needed to stand it up before we wanted to, but we did control it very well, managed to shut it down again. We had a winter plan that we based on from learning from the previous year, which really revolved about making sure that the business that we deliver every day was as good as it could be, that we were as efficient as we could be, that we had focus on trying to move people through the system as fast as we could, that our front door to try and get people to the right place first time was as robust as it could be. And we have put additional resource into that while we are in the process of recruiting permanent staff into those streaming and navigation services. We had dedicated escalation capacity that we were planning on using as needed, but we have had to use our procedure unit and discharge lounge during the whole period of winter, and those beds have not been enough often, and we have had horrible care across our ED and on our wards. Ward 8 at Wansbeck was always the plan to open for 8 weeks this year. It is still open, and despite that we're still out of our footprint just due to higher attendance than we've had and difficulty discharging out of the back end of the system. We've looked at ways to try and speed up both patients getting out, and we've had full hospital protocol daily for a long period of time, focusing down to individual patients, working across business units to try and support discharges as best we can within our system, and also using additional resource in the community as best we can. We've also been looking at processes to try and avoid patients coming into hospital, particularly around frailty services. One of the positive things that we've managed to put into place is call before convey, which the COTI team, frailty team, community teams in order to have a 12-hour, 7-day, 12-hour service where NEAS staff, nursing home staff, GPs can contact a frailty consultant to have a conversation about alternate dispositions to transport to the hospital. I think in the slides later on there are some figures about how that's gone. It's been very successful in terms of the initial avoiding transfer to hospital and providing different resources. We've still got quite a lot of work to do because we're being slightly hampered by what happens after that initial contact. So that's been going on since November and has definitely reduced some attendance to ED. On the back of all of that, just in case we're not also enough, we have had a couple of rounds of industrial action and we're just waiting to see what happens in the next month with that. Winter Plan Plus, I think we recognised from last year that despite all of the resource that we knew we were going to need, we were going to need more, and we've had to work hard with our other business units. We're currently out of our footprint again in the bone infection unit. But again, we're having daily conversations about how we can get everybody back into their own footprint and how we can make sure that everybody can be as efficient as they can in their own space. Despite all of that, our patient and staff experience, certainly the patient experience on the wards has been maintained at really high level, and we haven't seen a drop, particularly in terms of patient experience. Staff experience, we've had one round at the end of, in the autumn, which was very positive. There are areas where we know staff have been under pressure, particularly in ED, and they have had periods where they have struggled, I think, to provide the care that they want to provide with the continued pressure in the department. However, we've been working really closely with them, providing as much as we can to make sure that our patients are safe, they're safe, beefing up the services that we can offer, putting in place protocols, particularly around lodged patients, and safety measures that we can put into place to make them feel more confident that they're able to deliver the care they want to the patients. We've got the the national survey that is coming out at the end of this month, so we'll have a better idea of how people have been feeling over the last few months. But from conversations that we're having, I think people seem to have got over the worst hump of it and they're coming back up again. And I think we can see that as well with the evidence that they're still continuing to want to deliver quality improvement projects. They're still working really hard to improve services and keep the patients safe. An example with that would be with the ambulance handover work that our nurses have been doing.
I need you to assume that people have read the slides because we're coming to the end of the class.
Okay. Despite all of that, our elective delivery has been really good. Our community nursing team have gone above and beyond, particularly in our rural areas, and managed very well in providing care to our patients in all rural areas. Talked about call to convey. We've got winter debrief coming up in the next couple of months, and a winter pressure review that we do every year, looking at mortality between that 4 weeks. We haven't got the final results from that, but the early review looks as though there aren't any areas that we need to be concerned about, and there's nothing that's outstanding.
I think we've got a report coming to board in March, I think, that will have gone over all of that.
We were planning to go through all of the slides, the rest of that's just for information. We've just the first two, sorry, that's all for just your information as part of
Can I just ask a quick question then? Appreciating that this was all the things and that you've already got a list starting, I think, for winter 26, which does feel like we're on a constant cycle. How are the teams feeling at the minute?
So I think they, despite the fact it's been busier this year, and I think there have been some ups and downs, I think overall the processes that were put into place based on last year, for example, the protocols around lodged patients, have meant that the system feels safer. It is still a balance, though, of making sure that what we don't want to happen, lodged patients and corridor care, becomes normal.
Yeah.
So we're aware that we don't want, despite the fact it feels better.
Yeah, and I think that it is worth feeding back to the teams at the board. Absolutely don't want either of those two things, and are committed to support you to try and eradicate that across the board. And I think we would all concur on that.
Indeed, yeah. At the same time, really thanking the colleagues for the effort that's gone into it. I think we're all really conscious that we're enjoying the get over, and it's called on a lot of quite deep resources from staff, and I believe from across the trust in supporting. Any questions or comments, Katie?
Yeah. Thank you, and it's brilliant the work that's happened, so thank you very much. Just one of the, when we approved, I think it was in June, the winter plan, one of the actions from that was to nurture and strengthen our organisational relationships with partners, so NEAS and primary care. I just think it would be really useful when we have the detailed review just to see if that has been strengthened or what we can learn.
Very good. Very good. Margaret?
And actually that's exactly what I was going to say. It was about our partnerships, particularly with the local authority and social services, and how that had felt. But a huge thank you to you, Jo, and the team. Phenomenal, the work that you do, so thank you.
That's great. Then thank you. We're receiving with gratitude while recognising how the challenge is still on. And we will have the chance to dig into it further in a couple of months, I think in March. Yeah. Excellent, thank you. Stephen, welcome back. Health and safety. Numbers are dropping. Most of the hours seem to be in the right direction.
It seems to be, yes, yeah.
That's really good.
Yeah, so the accidents, as you see, it went down a little bit in the last 2 months. We had 2 widows up from there, no widows 2 months beforehand. They identified in the report. One was the injured person was assisting a patient who fell and hurt their back. And the second one was the injured person cut their finger while using a meat slicer. Yeah, but both been investigated and there all actions put in place, so there's no real concerns there. The incidents for the abusive staff were reduced by 12 from the last reporting system. We've been working on putting a dashboard together with Datex, but we had a few problems with the Power BI, so I didn't want to give you the wrong figures this month, so the next report will have a more detailed report on there. We had 7 warning letters issued and 1 exclusion letter, so that was 100 in the year for warning and 11 for exclusion. But this is all going to be feeding into the violence prevention reduction strategy that we're putting together, which we've just, we're starting next week with staff engagement around each site and each business unit. We're going to different committees, etc., just to get the feel and get our violence prevention strategy out there so everyone knows what we're doing. The fire, we've had 9 incidents reported in the last, but no fires. Training, we've got 287 staff trained in November, 224 staff trained in December, which is really good. And we have 1 new risk about the appropriateness of the installation of cavity barriers over in the main building, but we've continued to work and monitor with the contractor. It looks like it's been an isolated incident, so we are continuing to monitor it on a weekly basis. So we've got no concerns about the rest of the stuff we've been doing, but again, we'll feedback if there's anything with high risk over there. But I think, like I say, I think it's only been 2 isolated incidents.
So how worried should I be about the fact that 8 of the incidents, the fire incidents, were not reported through Datex?
Yeah, I would say no, you should be really concerned because it'd be just be minor incidents, maybe say a fire door incident, there's nothing, there's been no smoke or anything like that. They're really good about reporting them incidents. So
it's not a training issue, it's a sign of the relative...
yeah, it's an ongoing reporting issue where we have across all our areas, yeah.
Thank you, Kate.
So I don't know.
Oh, no, okay. Thank you, Stephen, that's a really clear report, and the report itself is really clear. Any comments or questions, Stephen? We'll see you again soon, won't we? That's really good, that's great. Kate, People and Organisational Development Report and Dashboard. This has gone through P&C, hasn't it? So, escalations for the board?
Yeah, so generally good performance, still improvement in some areas. Sickness absence it did increase in December, but it's a whole percent below what we were in December 24. And there has been a decrease in mental health absence, and we're at the lowest it's been since May 23. Still a lot of work to do on absence, but we are seeing significant improvements from this time last year. Just to pull out a couple of bits of work, so resident doctor 10-point plan, work is still ongoing there. We've received the results from our baseline survey, and we're sitting in mid 80%. And sexual safety charter as well, there's work going on with that, and that came to PCC yesterday. Just a nod to wider participation team receiving the gold standard for work experience. And we received a re-accreditation for the Better Health at Work award for health and wellbeing for our staff as well. And then we're doing bits and bobs as well.
Thank you, Katie. Any explanations from your side?
Nothing further.
Yes, Richard.
Second question, which was the occupational health shared service. Probably not surprised that our partners got to compress timelines, but are you comfortable we're going to be able to manage a professional transition?
Yes, I am, thank you. And we've just received notification today of the new provider. However, we've been talking to them all the time anyway, so we've got a production plan in place.
Excellent. All good? Happy to receive that report? Then
Can I just add one quick one? Just from PCC yesterday, I know it's appropriate to bring it in here, we had a good discussion around the real living wage paper, didn't we? You just wanted to touch on that here.
Yeah. We took the paper, we've been discussing about whether we become a real living wage employer, and we had a number of execs there yesterday and non-exec directors, and we've had a very detailed paper around the real living wage. Lots of pros and cons. I think the outcome was that at this point in time we wouldn't look to become a real living wage employer. However, the cons on that needed to be carefully navigated, because there are many reasons why not, but there are other things that we can do to support our low-banded staff.
Good. Thank you for capturing that. It is a tricky issue, and it's quite technical, the reasons, the arguments for not. And as Kate and colleagues know, I'm passionately in favour in principle, but I understand the pragmatic arguments that suggest that we wouldn't be able to fulfil that without breaking some of the agenda for change obligations. So thank you for highlighting that. Anything more arising out of the dashboard? Then I love this paper, the trust behaviours come out.
Yes, thank you.
Yes, I think you get again.
Yeah, so this again went through PCC yesterday. Just a bit of a reminder, last summer we decided to look at our current values, and we did a number of focus groups across the trust, so asking staff what they thought about the current values and what they wanted them to look like. Generally, they really like the values, they think they're very relevant, but overwhelmingly it was the simplification of the values, how we can make them more understandable and more simple. So, after a number of focus groups and discussions, we have refreshed the values, so it's very important they're not old or new values, they're refreshed values, to patients first, respect and always improving. We also brought to a board around the big signals as well, so we had 8 big signals, and again, in the spirit of simplification and for staff to understand what we are doing, we reduced them to 4. And how we do that will be through our Northumbria Way, and Northumbria Way is putting patients first, respecting everyone and always improving. So hopefully that flow, staff can start to see what that flow looks like and understand it really well in that forum. What we wanted to do under the refreshed simple values was to look at compacted behaviours. So we felt that it was probably a good time for a bit of a reset around what staff can expect from the trust and what the trust can expect from staff. It's very important this is a two-way relationship, not just a one-way. So you'll see there we've kept it to 3 or 4 points under each value. And this has gone through a process, and it is at an average reading age of 12. We wanted to make it really, really simple and understandable, and we have tested that out. We went through this at PCC yesterday, and there's a couple of changes, nothing material, just a bit of understanding of what's the trust and what's staff. We don't want this to look like managers and staff. It needs to be an organisational and a staff perspective. So I'll take a couple of those comments and then maybe a few tweaks under that. This will be socialised across the trust from the 1st of April. There is going to be a launch. There will be some branding that goes alongside the values and the big signals in this. And this will start to appear in appraisals, induction, job descriptions, and we'll start to put it into everything that we do so staff can understand what that looks like. I've just added this final slide on because as part of all of that refresh, we felt it was also time to look at our consultant recruitment. It's very successful, it's a great process, but I think with next generation consultants coming on board, we felt it was time to look at the competencies. We've done a huge amount of engagement, one-to-ones, focus groups, and we have now a refreshed competency framework. We've done a number of things, including the weightings, which is the competencies, but I think more importantly, we've got a huge bank of questions now that the panels can look at and pull from and really, really get in depth in the interviews. Panels need to include an exec director, and we really want that panel member to have attended the training, so we've commissioned some training which has taken place and I've attended that as well. So we plan to launch that on the 1st of March and this will go to CPG in the middle of February. And alongside that, with the agenda change staff, our VBI recruitment, so our value-based recruitment, will be refreshed in line with simplified values, and that will launch the 1st of April.
Okay, that's great. To remind the board, the streamlining of values has been subject to discussion in board over the last year. So I think that bit we have all previously improved. But the compact is new. I must say I really like it. I hear the tweaks, but I'll hear comments in a moment, but I'll be looking to see whether as a board we approve the compact after discussion. I'll take Richard first and then Bijou.
Yeah, like you, I love reading it. I think it's really good documents. Every organisation comes up with a set of values, very few unpack them, and I think this has been unpacked really well. My previous employer, they did a similar thing. I turned up to a crisp 20-page document. very few people read and even fewer acted on. If we can make this understood and communicated across the trust, embed it in our recruitment and appraisal methodology, this could be really powerful. I loved it.
Oh, that's great. Bijou, and then Ross.
Yeah. So again, like Richard has said, I think this is a brilliant piece of work, and thanks to the team who've taken time to make sure that we have engaged fully on it. I think you'll start to see as well more and more a reflection in a lot of what we do around simplicity, and that is more about we have 12,000 staff that we need to communicate with. If we can't remember some of the things that we talk about, so if we can't reel off the values, if we can't reel off our big signals, how on earth do we expect anybody else to be able to do that? So I think you'll see, and there was a conversation at SQ&I as well around improvement, so we've tried to simplify that improvement approach as well, all in line with what you see here. So you'll start to see the thread. Again, none of this is new, so we need to be mindful that we're not getting rid of the old, starting new. It's a natural evolution that you would expect to see, and a natural kind of refresh. And it fits in line as well with the submission of our 5-year plan later on next month.
It's a gift for comms people, isn't it, Ross?
Yeah, I was just going to say thanks to sort of Kate's team and the internal comms team as well, who've done loads of work on this, almost over sort of 18 months now, I think, to put it all together. And it's going to be seen in advertising public relations that there's nothing more complicated than simplicity, and I think we probably learned that scope over this as well, but I think we've got a really good place, and the testing we've done with staff as well has been really well.
Maria.
Thank you, Chair, and thank you. It is a brilliant piece of work. I particularly love the line under respect for how it feels to walk in each other's shoes. And I think that underpins a lot of the discussions that we've had even in today's board meeting about various issues that have been raised through the Freedom to Speak Up Guardian. I think that is a fantastic approach. I have a question as well, and the question is around the values-based recruitment as part of the consultant process, and I just wondered if that's something that's overt as well, because that's, yeah, thank you.
Yeah, so the competencies fit under each of the values, so we will absolutely want to make sure that was included.
Very good. Then, yes, Reverend.
Just briefly to say that I think it is fantastic, and I think it's so good that it's applicable. You can see how it's applicable across all areas of the group, and I think particularly for NHFM, I think it's really sort of a very alive document where we can really use it, and it can be good for us to embed and simple for us to embed hopefully within the organisation. And just to note that, you know, earlier on I think I demonstrated that I can remember the values, and I'm not known for having the best memory in the world, so I think again that's probably a good application.
You're not alone in that. All the evidence suggests people of our age can't remember more than 3 or 4 items at any one time. They pretend to.
It's true. Your time will come.
Yes, time will come. People of most of them. Great. So, asked to approve, noting that some of the minor wording might be tweaked, but certainly approving it in principle with thanks. And looking forward to the external the internal comms that will start to roll out and external in the spring. Thank you very much indeed. Now we're on to the Education Quality Improvement Plan, and in this paper wins the award for the best executive summary of papers today, and that is praiseworthy, but it's also just a little nudge to other executive colleagues. Not all of the executive summaries were as good as Ian's. So Ian, over to you.
Well, thank you.
Doesn't mean the content's anything, but the subject's great.
I'm here to provide a very high-level overview of the self-assessment report and the quality improvement plan, which are both rather larger documents that are in the reading room, and this is on behalf of the Education and Training Board. The purpose of the SAR and QUIP, really they're part of our statutory reporting back to Health Education England, summarise our achievements and challenges, our plan for improvement, but also that governance and assurance around the 20+ million pounds of funding that come into the organisation for training both medical and non-medical clinicians. So this is to give a little flavour of what we're up to. This is where Education and Training Board sits. We report into people in OD, and underneath us each of the undergrad, postgrad, medical and nursing, AHPs and others report into Education and Training Board, which meets alternate monthly. We, in parallel, over on the left-hand side, there's the Education Quality Panel, so that's our governance structure for assessing departments and has input from clinical and non-clinical members, and we've got non-exec representation there as well, so it's a fairly robust forum for us to assess education and training within the organisation. We're asked, as part of the self-assessment report, to list 3 successes. I mean, we've got lots, but so we have to, as a team, pick out the top 3 that we think, but we could talk for ages about them. We were, over the past year, the top-ranked acute trust for training experience on the GMC survey, which is a nationwide survey of all doctors, postgraduate doctors in training. We've been awarded the NHS England Gold Award for work experience, and we got Gold Award from the 5% Club. So we are a good place to work, we're a good place to train, and we want to keep it that way. We do, however, have challenges. We're asked to come up with 3. I've actually, in brackets, there's a 4th there, and we'll get to that bit. We've got challenges as everyone else does. Money gets less and less kind of available, so introducing new innovations like the management and leadership framework is going to need a change in the way we work as a directorate. The loss of the level 7 apprentice levy funding that we can access is going to squeeze some of our postgraduate training, particularly outside of medical specialties. Across the piece, we've got increasing numbers of students who are coming to us and finding places for them to go, both inpatient places and outpatient placements is proving really challenging. As clinicians, as the system gets busier, training is one of the things that can be squeezed. We need to keep it high up because it's part of our workforce development. We need to keep it high up there on the priority list. So it's not just about the patient in front of you. It's about the patients that are going to come in weeks, months, and years to come. I've put in brackets a fourth risk just because it's not in the reading room. It's not in the SAR at the moment, but there is an emerging risk that's become apparent around postgraduate training in obstetrics and gynecology. I've just put it in there because it'd be remiss of me to come to public board as an emerging risk that really needs mentioning.
Yes, so we've picked that up, and there's been initial discussions in SQ&I, and indeed later on today.
And that's and there is a plan in place, but I don't want to overlook it. So each department on that organisational development chart is asked to come up with their quality improvement plan for the year. Can't go through the entire thing, but it's split into undergraduate, postgraduate medical and multi-professional. And some of the examples are things like how we recruit to senior leadership roles. It's becoming a challenge across the piece, but there are plans in place to make it more attractive, make it more doable. Scheduling and placement management, so how do we look at our educational estate, both kind of in terms of time and in terms of physical places. How can we make it visible and then match up the trainees to those placements? And then how the plan for implementing new standards. Every department is continually having new standards issued year by year, and we need a clear plan for how we go about that. So if you care, if you've got a few hours spare, you can read through the 50-odd pages of documentation that the SAR equip are fairly thorough. They've been through our Education and Training Board. We're happy that they represent where the Trust is up to at the moment.
Ian, thank you. And actually, since you were kind enough to attach the 78-page submission, you can assume that the board has looked at it, because they're very, very good that way. That was a great and clear presentation. Positive story. Questions or comments? We will be being asked to approve this because we need to approve the submission. Margaret.
Great report. One of the things is just the flavour of multidisciplinary education, because that doesn't always come across, that how you bring all the professions together and the learning that you do.
Oh wow! Yeah, so at undergraduate, I mean we've got those. Undergraduate level, we have multi-professional faculties. So our undergraduate team have nursing, midwifery, pharmacy, physician associates. So we have a faculty that's multi-professional and will often do teaching together. We get the physician associates and the medical students together. Postgraduate level, we are doing kind of in situ team simulation exercises, so you get the whole team in a real environment and working together in their real roles. One of the problems with things like simulation is often people feeling like they have to pretend to be someone else, whereas actually if you go in with simulation into a team and people adjust themselves, you can really see how a team works. So there's, I mean, we could talk all day about multi-professional education, but we've got both faculty and also we live it.
Yeah. I mean, we could talk all day, particularly because I'm from an educational background, but I'm not going to. But it's just when I have gone round and talked on some of the wards, you know, it does seem, even then you describe sort of the clinicians or the associates, but actually not true multidisciplinary education. And particularly I'm thinking around in midwifery, when I've talked around, there doesn't seem to be as much coming together. So that might be something to think about in the
Yeah,
future.
and-
Happy to have a conversation outside of here.
Yeah, and again, highlighting the O&G issue, that I think that is one of the issues, and that we need to address. When I look around other departments, it is more embedded.
Okay, so noting the importance of multi-professional linkages, maybe needing even more strengthening, that has been a universal challenge in the NHS and beyond. Are there any other comments on the submission? Are we happy to? Oh, sorry, Jeremy.
I mean, it's just to say it's a really, really strong document. And the number, the amount of education that we now undertake, and the number of people, I don't know if they're artwork, but I mean, we are an enormous provider of education in the Wars, and it's a credit to all of yourselves and your team to the outputs that we get from
And it's fundamental to the success of the trust, making sure that we're doing that. So you're pretty pivotal in your team here. See,
I'm just wondering about the 5% club. Looks like a really valuable thing to strive to. I just wonder in practice, do we know how we match up to the figure of 5% in terms of our workforce?
I haven't got the figures. We were given a gold award, so I'm assuming we match up pretty well, but I can find the figures for them.
Sometimes those awards are, an aspirational thing to work towards. I just wonder if it's maybe a metric we might want to consider in the future.
Yeah. Okay, the future reports. Let's just see if you can give us something on that. Good. Then I'm asking for the board's approval of the documentation for this submission. That's great. Ian, well done. Thank you very much indeed. Right, we're into the last lap, and we've got some governance sections. The CQC Regulation 17 on stakeholder engagement to Ross.
Thanks, Chair. Yeah, this is the regular regulation report. Pleased to say we're fully compliant. A few things to pick out. I know I say this every time, but we're really focused on accelerating on our face-to-face engagement efforts. That complement a lot of the sort of digital and virtual stuff that's out there at the moment. This time around, one of our World Cafe events proved really popular, and we did it for children and young people, and that was a really successful with some people's views on health and our lifelong care strategy. The next one is in Alnwick next week, and I think that's sold out now. So again, we're looking forward to another really good event. We haven't neglected the digital side though, so you can see in the report all the various topics we covered using our Have Your Say online forum. And again, I was going to say, Kate beat me to it, but I was going to just a word for the wider participation team who play quite a big role in our engagement as well. And again, won that award this time around, but played a really strong role in the community promise particularly. So big thanks to them.
Very good. Any comments, questions? No, happy to receive. Thank you. Chris, you win the award for the most nerdish title to a paper, to a policy on the strategy.
Yeah, so this is coming to the board chair because this policy is the only policy that's owned by the board.
Yeah.
And there's been changes to the policy, which is a response to an internal audit report, and the changes are in Appendix 6. It's around the guidance of how to have risk registers.
There's basically changes in the names of the committees and the removing individuals' names, isn't it? It's pretty trivial changes, but it's ones that require board approval.
Indeed, yeah.
Okay. And you're recommending that to us? Anybody got any queries on that? Good. We're approving that change. Rather more significant, we've got the BAF.
Yeah, thank you. Just to remind colleagues that the BAF's around looking at our strategic objectives and make sure we've got the priorities right and the actions and any mitigating actions we need to do around any risks to achieving our principal objectives. And also just to remind that the BAF has been through, or the parts of the BAF have been through each of the subcommittees that are relevant to the BAF, so it's had a good air in each of the subcommittees. We've noted in the cover paper there in terms of what changes, if any, have been made at each of the committees. The slight issues around timings of committees and board papers coming out. So I think maybe in the future cover papers we might be a month behind in reporting, but we should put the, kind of have a lag in reporting, but at least note them on the cover sheet there. And I say that each of the areas of the BAF that each committee is responsible to have been through that committee and had that update added into those committees.
And we're having a much bigger review in March, aren't we? A reworking in line with the streamlining of the big signals, etc.
Correct. We've had some good conversations at SQN in particular at FLIP around how we use a AAA report to inform the BAF and link it back to the AAA report and make sure that anything on AAA is contained within the BAF as a way to kind of make sure that the two are aligned.
Very good, very good. And can I just check, it's gone through the various committees. SQN, Maria, anything to highlight from the discussion?
There was one thing around health inequalities that we wanted clarification on, but there was some cross-cover, but I don't think we came to a final definitive answer.
Okay. A bit more work to be done on that. So, for IMT, Dave, was there anything, discussion of the BAF at IMT that we need to be alert to?
I don't think so. I think we go around sometimes just to make sure that security's in there and that we'll cover off enough update.
Okay. And Paul, anything that came out of FIP? I'm asking you because Phil's had to leave in relation to that.
No, nothing material.
Okay, Katie, for people and culture?
Yeah, it was a good discussion yesterday. There's a lot going on externally with the medium-term plan, 10-year plan, and the need to just rethink the principal objectives for the background that relate to PCC, making them a little clearer and more appropriate. So that we'll be looking at that in detail.
Okay, so there's work in hand. There's some points that the committees are picking up. We know that we're seeing a revised version that will bring us into line with the big signals later in the month, later in the spring. But at this point, any further comments on the BAF as submitted? Are we happy to? Are we approving? I don't think we're approving it. Oh, it says to approve. Are we approving the amendments to the BAF? Or just noting?
So there's always a bit of disparity about whether the BAF is owned by Assurance Committee or board, but I think as board, as the overall owner, I think it is approving the changes there. Okay,
so we're being asked to approve, and I'm seeing nods around the room. Yeah, that's good. Now, thank you. We're into the items for escalation, and I know if one's an observer to a committee like this, it can feel like really, really important stuff is just being nodded through without consideration. But the reason it's put in like this is because it's been chewed over in great detail in another place. So the purpose of these items are simply to escalate anything that hasn't been sufficiently addressed in the Tier 1 committees. So with that as a front, first of all, the nursing and midwifery assurance report. Marion?
No, nothing further to escalate, thank you.
Okay, anybody wish to raise anything there? And the Associated Health Professionals Assurance Report?
Same for that, nothing to escalate, thank you.
Any questions or challenges from the board? No. Learning from Death Report, Jeremy?
Nothing to escalate.
Similarly, nothing to escalate. Okay. The monthly SQ&I dashboard, Chris?
Escalate.
Okay, thank you. No challenges or questions from the board. The Corporate Safety and Quality Report, Jeremy? Nothing. Okay, it's getting a clear run, which is a sign that they've been properly chewed over elsewhere. And then we're into Paul and the financial compliance.
Nothing to escalate on target, all financial targets.
Very good, very good. Then, no question. No. Then we're into any other business, the agenda for 26th of March, our normal attempt to predict the future. All okay, any points people want to put in for that? How's the meeting gone? In a moment I'm going to ask our observers if they've got any comments or questions, but first of all, within the room, how's it felt? Nodding heads. Nodding heads. Thank you. Then colleagues from NHS England, anybody wish to make ask a question or make a comment, Christian?
No questions from me, but thank you very much. It's been really helpful.
Thank you, Lisa.
No questions from me, thank you.
Okay, that's good. Yeah.
Can I just check, Christian, did Anne-Marie join? Was she able to join, or because I'm conscious
She's
we
joined on
haven't...
her phone, but so basically she has an internet access on her suite, unfortunately. She joined on her phone, but that didn't have good enough signal, so we're going to, it's
That's
fine.
okay.
We will
Yeah.
I
pass
just
it.
didn't want her to miss out.
Yeah, I saw her appearing for a short period of time.
On YouTube.
Yeah, she can go onto YouTube if she wants to have pleasant entertainment. It is public and it'll be loaded onto YouTube when, Ross?
It's normally within the week, I think. Isn't it?
Within the week it'll be on YouTube. So there you go. Thank you. Then colleagues, I think we're done. I've had no notification of questions from the public, so I think we're done. We've got private board starting later on at 1 o'clock. So back here, I've given you an extra 10 minutes for lunch. Thank you very much indeed.